Great. Can everyone hear me okay? Hi. Oh, sorry. Hi, I'm Jo Harris. I'm an analyst on the information management team for eCritical, the Tracer group. And my talk today is turning data into information. So the goal of, I'd like to start with a quote. The goal is to turn data into information and information into insight. And this is a quote from the former president of HP. So this is a mission that we try and do at Tracer. So just to quote, healthcare data is an organizational asset, but in itself it's not useful. More and more we are drowning in data, but we have to ascertain what it is trying to tell us. Think perhaps of how many elements are involved in an Apache score as data, and how much time and work this would be to calculate by hand, rather than just having the information as the Apache score. That's the beginning of information. This is the information value chain. This is the process of turning data into information. Data is the beginning. It's used and created in patient care, but does not show the bigger picture. An example of data would be if we were to give you a spreadsheet with a row for every time a pain score was entered into MetaVision on a patient. It would not be very useful, and it would be a lot of data. Working with the Delirium Metrics group, we meet every Thursday at 7 a.m., so thanks for that group. We define the analysis that turns the data into information. This information is then fed back to the SCN and then to the units for them to act on and influence the outcomes. So talk about the process for KPIs. So these are our so we need to start with determining our KPIs, our key performance indicators. Then we need to figure out how to actually operationalization them. So the questions we ask are, what are the inclusions? What are the exclusions? What is the workflow? So the adult CCSCN group has defined KPIs, and we meet to formulate metrics around these measures. Here are three of the elements we have on our KPI template document. You can see it's a complex process. We look at data sources, definitions, numerators, denominators, many more. So on a conceptual level, we might ask, how much pain? The analysis process asks, what is pain? How is it charted? Where is it charted? What are the exclusions? The what ifs? Is the patient sleeping? And to that end, we're looking at introducing a change to capture in MetaVision. And I know this has been a pain point for a few of you this afternoon, that will be something we will be addressing to look at that detail. So just to say the devil really is in the detail, and the details do matter. So here's our pain dilemma. So the metric we were trying to measure was the compliance with documented pain assessment, looking at the number of, looking at the compliance with documented Q4H pain assessment. So at first we thought, well, that doesn't sound too bad. And then we started to think about it more and the ways we could do this. So what about the number of assessments in the day? But what happens if you do all the assessments in the morning and then nothing at the rest of the day? Timings between assessments. We need to differentiate 4 hours and 5 minutes from 7 hours. Then we looked at hard cutoffs and intervals. What if one measure was done 5 minutes early? Does this mean there's a block of time with no measurement? So really not as simple as we thought. And something key to point out is the metrics must encompass clinical workflow practice, not define it. So this is the solution we came up with, which is, I promise, not as scary as it looks. So imagine by each patient's bedside, for every unit in critical care across the province, there is a timer. And when there is more than 4 hours from the last pain assessment, the clock starts ticking and continues to count up until there is another pain assessment done and recorded in MetaVision. The time is then measured for the whole day. This is done for every patient, every day, and aggregated for reporting. And we also use the same methodology for looking at RAS Q4H compliance. So hopefully that addresses some of the problems. So the next thing we want to look at is, once we have these metrics, we need to get this information readily available on demand. So this is reporting the house that Delirium built. So we do this through through tracer reportings and dashboards, which I'm sure you're all very familiar with. So we're going to go with an analogy. It's like building a house. It's not a fast or easy project. So we start off with our databases. We have Tracer, which receives data from MetaVision and from other systems. And the frontline staff are key. You create our data bricks through charting in MetaVision. So thank you for that. This is where our data journey begins. The QA team, they check our bricks for defects and fit. The next step is the design. Then we create the blueprint for our house. ETL, which is extract, load, and transform. The ETL process, it identifies the bricks required and moves them from MetaVision to Tracer. The data is extracted and transformed to be available for analysis, such as calculating oxygenation from all the many different ways it can be charted. This is then loaded into Tracer for reporting. This is a time-consuming and an extremely complex process. We have 2 FTEs that do this, and sometimes we wish we had more. An archive load to pull previously charted information can take a week just due to the sheer volume of data. So the ETL builds the foundation of our house, and this is a solid foundation is crucial for success. SQL. This is our structured query language. This is the initial query that builds the framework. So currently, to get the data, because we don't have this dashboard, we're running actually SQL queries, and this is how your data's being produced. And I don't know if you can see very well on the slide. That's actually just a tiny snapshot of one of our queries. Sorry. So the Tableau dashboard, once we have an agreed upon design, a Tableau dashboard is built. This is the final stage. Then we move to testing and clinical validation, and this is when we check the build is solid. We slam all the doors and see if the house falls down. Once the dashboard is developed and ready for release, it is released in a Tracer release cycle, and then the house is ready for its occupants. So optimization and evolution. So I'd like to have another quote here, just to say, perfection is the enemy of good. So we don't want to aim for Highclere Castle when a townhouse is all you need to get you out of your parents' basement. It's good to start the process. Some information is better than none. With time, you'll need a bigger kitchen, a nicer house, but come and talk to us. These are not static reports. We can help you with your redesign. This is a dynamic process. So these are our Tracer reports. They're available to everybody through Insight, not just senior leadership and administration. All you need is an AHS login. They're available 24/7 on demand. And if you would like more information on it or a Tracer presentation for your group, please reach out to us. And if you see here, if you click, you will get a little splash screen, and it gives you a brief description of all the reports. You just click and it will open your report of interest. So this is a piece of work that we've been doing, developing your new Delirium dashboards, and you can see we're looking, we're looking at significant pain and ever delirium, and ever delirium is the percentage of patient days where the patient was delirious. And then in the graph below that, we're looking at Q4H compliance, and that's for both RAS and pain charting. And then I didn't have room on my slide, but just underneath those graphs, those are our, your new core metrics. So you'll be able to, when we release this, you'll be able to log in and see this on a monthly basis. And then the next graph is the next tab, and this is looking at your ever delirium and screening compliance. So when we started, I think possibly 3 or 4 years ago, when we started the delirium work, our major focus was around screening compliance. But in a lot of ways, we've moved on from that, and we're starting to look more at ever delirium as an measure. So this is our final slide in the report, and this is gives you the ability to look at ever delirium as a site-to-site comparison. And I just picked a few, so we wouldn't have too many lines. So just to say in summary, this is a cycle of complex work with very detail intense, which helps to support change at the bedside, and it's a collaborative process done with all of you. So in closing, I would like to finish with my mythical creatures, my magical unicorn, and I actually have a magic information button.
That was easy.
But I'd like to say it seems somehow to be defective because it hasn't really helped me. So thank you.